bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAPHC's programs and activities: Hello, everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. And welcome to today's webinar, which is titled Ebola in the Interfacility Critical Care Transport Environment. And certainly nothing more timely than Ebola, with all of the news and everything, which maybe died down a little bit in the popular news media over the last week or so, but certainly if we go back even a couple of weeks, it certainly made much of the front pages. Here, just to give some background, this session started as a result of a conversation from CAPHC's Interfacility Transport Steering Committee, which is a committee that CAPHC's had since 2008, but that has largely been focused on sort of developing standards of practice and guidelines around interfacility transport of the neonatal and pediatric population, as well as the maternal population. And one of the conversations was around, this whole issue with Ebola, and in particular, the high-risk situations that might arise in the interfacility transport environment. So we're really excited to bring this presentation with some really excellent speakers that I'm going to introduce in a moment. But we do hope that this will be the first of many to come from our Interfacility Transport Steering Committee, really focusing in on some of the variety of issues that the transport community faces across the country. We don't have any on the CAPHC Presents schedule yet, but do keep an eye on our calendar in the coming year, as we do expect to have regular sessions from that committee focusing on these various issues. So it's now my pleasure to introduce the panel. We do have 4 excellent speakers lined up on this panel today. And starting off, I'll be introducing Dr. Russell McDonald. Dr. McDonald is the Medical Director at Orange Transport Medicine and is the Medical Advisor for Toronto Paramedic Services. He's also an Associate Professor and Co-Director of the Emergency Medicine Fellowship Program in the Faculty of Medicine at University of Toronto. And Dr. McDonald also practices emergency medicine at Sunnybrook Health Sciences Centre in Toronto. He also has a master's degree in public health, which really lends itself to this issue. It's almost the trifecta of areas of expertise when it comes to Ebola in the transport environment. So we're really excited to have Dr. McDonald here. And following Dr. McDonald, we have Dr. Andrew Travers, who's an emergency medicine physician at the QE2 New Halifax Infirmary and he's also the Provincial Medical Director for Emergency Health Services in the province of Nova Scotia. He's also an assistant professor and attending medical staff at the Dalhousie Department of Emergency Medicine, with cross appointments in community health and epidemiology. So once again, this great cross-pollination of emergency medicine, transport, and community health and epidemiology. Following Dr. Travers, we have Mark McKenzie. Dr. Mark McKenzie is Alberta's Provincial Air Ambulance Alberta's Provincial Air Ambulance Medical Director for Alberta Health Services EMS and for STARS. STARS is, I won't claim to know exactly how to describe STARS, but they're responsible for the air transport in the province of Alberta. He's also an emergency physician in Edmonton and a STARS transport physician, and has been involved in transport medicine and medevac oversight for over a decade. And wrapping it all up, we are pleased to bring Dr. Allan de Caen. And Dr. de Caen, in addition to being a pediatric intensivist and clinical professor of pediatrics at the University of Alberta and the Stollery Children's Hospital in Edmonton, he is also the medical director of the PICU transport team at Stollery, but he is also, more importantly, the co-chair of one of the co-chairs of CAPHC's Interfacility Transport Steering Committee, and one of the people who really led this session and the development of this session. And really, I want to thank Dr. de Caen for bringing all of these experts, his colleagues from across the country. So without any further ado, we're going to hand the virtual podium to start the session off over to Dr. Russell McDonald, coming to us from Toronto. Over to you, Dr. McDonald.
Thank you, Doug, and good morning and good afternoon to everyone. I'll just get my presentation up and running here. I'm Russell McDonald from Toronto. I want to start our presentation by talking about Ebola in the interfacility critical care transport environment. I've got no identified conflicts or interest or any commercial interest in anything that I happen to mention during the presentation. My outline is fairly brief, just giving you an idea of the current status of the Ebola outbreak, an introduction to patient transports in the province of Ontario. And I'm going to spend a bit of time talking about the lessons we learned during the 2003 SARS outbreaks, which impacted pre-hospital care and patient transport in a significant manner, and how we can translate that information and those lessons learned into what we're dealing with right now in terms of approach to a high-risk patient transport, modification to the routine practice and the routine operations involved, and then giving you a bit of a risk assessment and perspective on what we're dealing with right now. And the information I've got is current as of a few days ago. Ebola, briefly, is an Ebola 101. Ebola is one of many different types of hemorrhagic fevers. Viral hemorrhagic fevers are caused by 5 related families of viruses, and they're all dependent on an animal as their host. Humans are not the natural reservoirs of these particular viruses, and humans get infected when they come in contact with the infected host or human-to-human transmissions. Ebola and their relatives cause sporadic, unpredictable outbreaks. But what's common to all of them, and this is an important fact, is that they require direct contact with infected blood or body fluid to transmit the disease. Unlike SARS, Ebola and the other viral hemorrhagic fevers are not airborne or droplet spread, and that has implications in terms of how we protect our staff and how we prevent secondary transmission. A quick map of the history of the outbreaks of viral hemorrhagic fevers, particularly Ebola. They're predominantly in sub-Saharan Africa, and cases that have popped up elsewhere in the world are always secondary transmission cases or imported cases. The animal reservoirs are in sub-Saharan Africa and found nowhere else in the world. In terms of our current outbreak, the status in West Africa as of a few days ago, almost 1,600 cases. Mortality is approaching 5,700 deaths. So if you do the math, about 1 in 3 patients who develop the disease in West Africa die. Unfortunately, it's having a greater impact on healthcare workers, 575 cases of Ebola amongst healthcare workers, and of those, 333 have unfortunately died in caring for patients. Let me take you to my home province now in Ontario. I'm going to talk about our air transport system and about the land transport system within the City of Toronto itself. Orange is the provincial air and land critical care transport system. It provides land, rotor, and fixed-wing transport in the province of Ontario. It does about 19,000 critical care transports a year. Our staffing configuration is critical care flight paramedic. We do have a dedicated pediatric team in the Greater Toronto area. And the whole system is managed by a single provincial dispatch center with a single medical control and oversight authority. So it's a one-stop shop if you have to fly someone in the province of Ontario, or you require land critical care interfacility transport within our major population centers. So the areas along Lake Ontario, Hamilton, and Toronto, as well as the National Capital Region in and around Ottawa. Within the City of Toronto itself, Toronto Paramedic Services is the municipal 911-based EMS system. It's Canada's largest single municipal system. It operates its own communication center, now taking upwards of 2/3 of a million emergency calls a year and responding to just under 1/3 of a million emergency calls each year. Same principle, a single medical control and oversight authority. And because healthcare in the Greater Toronto area is very highly regionalized, there's a lot of interfacility transports that get done by the land ambulance service within Toronto itself. In 2003, Toronto was impacted by Canada's SARS outbreak, and there was a lot of lessons learned related to SARS. What made the front pages of the newspapers very quickly was that SARS was being spread as patients were moving within the regional healthcare system. So the headline on one of the newspapers, "Every ambulance's Trojan horse," rang bells with a number of us within the pre-hospital system. And it impacted our providers as well as the way we do our operations. And I want to talk quickly about some of those lessons that we learned. Unfortunately, 6 of the land paramedics developed SARS. Thankfully, none of them died. And we recognized that PPE did not eliminate the risk to the providers. Now, bear in mind, SARS was droplet and potentially airborne spread. The concept of work quarantine was identified. In other words, staff came to work and were quarantined at work, went to work but had restricted duties. We did in-house staff monitoring in terms of health and well-being to ensure that if they came in contact with an at-risk patient, they were watched on a regular basis. We recognized very quickly that the frontline staff needed a single source for effective communication so that they could trust one source of information as opposed to reading things from multiple sources. And we recognized very quickly that training them once in PPE use was not good because of skills decay, and that training needed to be done in some cases every week or every second week to maintain the high level of skill required to protect our staff. We also recognized organizationally that a single command and control structure was necessary, and that's not just within the City of Toronto, but provincially, to keep track of everybody, all our patients and all our staff. We needed a single source for directives and relevant information, so that was set up by our Ministry of Health. There were major problems in supply chain interruption. I mean, if any of you have wanted to order PPE in the last 3 months, it's unlikely that you've had your order immediately delivered. We needed to inventory all our possible resources, and since 2003, most services have kept an ongoing tally of their inventory so they know what they have at any moment in time. Protection of key vital operations like dispatch, like vehicle maintenance, was essential in order to keep the service running. And operationally, there was no pre-hospital SARS bypass to drive somebody from their home, so to speak, past a couple of other hospitals to a quote-unquote SARS hospital. That was not put into place. We've actually replicated that concept in the current setting. So translating what we learned from SARS to what we are currently doing in Ebola has captured a number of categories, and I'm going to quickly talk about each one of them. The Public Health Agency of Canada put together an outstanding document with guiding principles and released it on the last week of August. It has a section on interfacility transport that covers basic principles. I wrote that section. And this is something, if you haven't looked at, you can download their document directly from the PHAC website. And it identifies a number of things that can help guide in terms of patient management as well as interfacility transport. In terms of PPE, the concept of routine versus enhanced is something that we had learned from SARS and had kept in place. Routine PPE being what we recognize as basic things: gloves, and N95 mask, eye protection, and a good gown. And that's standard, and it's required in every situation where you're encountering a patient that might have any infectious illness or disease. The concept of enhanced PPE is adding to the routine PPE boot and leg covers, a head cover, and an apron. And in the current setting, with enhanced PPE, we are not currently advocating safety glasses or eyewear. We learned that during SARS, that people would fiddle with their safety glasses or eyewear, and that increased the risk of contamination. That's been found to be the case now as well with Ebola, with that case that was in Dallas, Texas, and how one or both of the nurses who got the secondary spread ended up contaminating themselves. And that's currently a CDC recommendation. All the items we carry in terms of PPE are blood and body fluid impermeable. And the enhanced PPE is used for the at-risk patient, even in the community response 911 setting. In terms of managing the actual emergency response, Toronto EMS has put into place a call screening and response procedures to try to identify high-risk patients before the crew even gets to the patient, and notifying the crew of that risk before they even make patient contact. In the setting of a high-risk patient, we use the typical ambulances with an enhanced pre- and post-response vehicle preparation. So the crews are notified ahead of time, and if it's an at-risk patient, there's a decontamination procedure that follows the transport. We'll, in the setting of a high-risk patient, assign a second vehicle and crew, and assign a supervisor for oversight monitoring and checklisting of all the procedures to keep this frontline staff safe. In terms of interfacility transports within the City of Toronto, non-critical care transports are done by the municipal EMS service using the same processes and procedures that I laid out in the last slide. If the patient requires air or land critical care transport throughout Ontario, Orange is the single provider for it. There's one specifically trained cohort of critical care flight paramedics who have been specially trained with enhanced equipment, and they use dedicated resources, so a dedicated fixed wing or a dedicated land ambulance to do these trips. We've chosen to go with PAPRs, not because it provides increased level of protection for our crews, but for crew comfort. We found that after about 30 to 45 minutes in enhanced PPE, staff got hot and sweaty. And using the PAPRs allows them to have an endurance within that PPE set up for 1 hour and 3/4 to 2 hours, which gives us more flexibility for the longer distance transports. We're also entertaining the use of a patient containment device for the transports to minimize the risk of spread of potentially infectious blood or body fluids within the aircraft or transport vehicle itself and contaminating other members who might be assisting in moving the patient in and out. Right now, the patient containment devices on the market are not certified for air use, so we're in the process of dealing with Transport Canada to address that issue, and hopefully we'll have that resolved fairly soon. So that's a stumbling block we currently face. Ultimately, if you're setting up an interfacility transport process or dealing with 911 emergency responses, you want to plan before you actually get the call. So reviewing your infection control and prevention procedures, regular and ongoing PPE education. In the air setting, it's done on a quarterly basis. In the land setting, it's done with every single CME episode. Proper fit testing for the N95 respirator. The N95 respirator is the standard mask for both land and air in the province of Ontario. Making sure you have sufficient PPE supplies on hand. Trying to get your staff immunized. It might not be applicable to Ebola, but influenza and other things are probably a far greater risk. There's some medical protocol modifications, and I'm going to talk briefly about them. And setting up an incident management system command and control structure so that when this happens, you've got something in place to deal with it. I want to make one note that interfacility transports are rarely emergent and time sensitive, so you might want to consider using a dedicated team and specialized equipment so that you can focus your efforts particularly in education and resources in a small number of individuals to ensure that they retain the skill set. When you respond, obviously, do what you have to mitigate risk to your staff. Appropriate PPE, minimize the number of times you come in contact with a patient, modify the treatment if necessary, and not taking any non-essential persons or escorts on board. And I know in the pediatric population that has major implications, but from a risk management perspective, that's what we've chosen to do. In terms of modifying care, one of the biggest things in this setting, and as well as any other infectious diseases settings, is trying to limit or avoid aerosol generating procedures. So if you're placing or removing an advanced airway, suctioning or delivering any nebulized or MDI medication, you may choose to modify, forego, or in some ways deal with that. And we found that during SARS, aerosol generating procedures were a great way to spread a particular infectious disease. So in the setting of the systems that I'm currently dealing with in the Ebola outbreak, if a patient needs to be intubated, they're not intubated in the field, they're bagged and taken to the most appropriate receiving facility. In the interfacility setting, if there's any risk that a patient needs an advanced airway, it's done in a controlled setting in the hospital before we move the patient. Limiting or avoiding other significant high-risk procedures like needle thoracostomies, putting lines, tubes, or drains in, potentially limiting or avoiding the use of CPR, no routine finger sticks for things like random glucose monitoring, and then being very, very careful in minimizing your crew's exposures to blood or body fluid. So you can put a mask on the patient, making sure the PPE that's used is impermeable, considering wrapping the patient in something. If it's not a containment device, maybe it's a set of sheets or a blanket. And then any containers that contain fluid that are attached to the patient, like a urinary catheter bag or a chest tube, drain them of blood or body fluid before initiating the transport to avoid spilling. I mentioned briefly CPR. If a patient's known or suspected Ebola patient and they're at the end stage of terminal disease, the chance of a meaningful resuscitation with CPR is essentially nil. The Public Health Agency of Canada have placed a statement in the document I referred to earlier saying that patients at late stage for Ebola who've had an unwitnessed cardiac arrest have a minimal chance of survival, and under those circumstances, resuscitating efforts are potentially withheld and appropriately withheld. Once you've done the call or done the transport, careful cleanup of the vehicle that was used, whether it's an aircraft or a land vehicle. Disposing all the PPE and other items at the receiving center is easy to do. Proper and thorough cleaning and decontamination of the vehicle. and there's a variety of methods to do that. The other thing that's quite important in the cleanup after the call is providing good follow-up and monitoring of the staff. In some cases, critical incident stress debriefing may be needed, and then managing them proactively if they've had a potential exposure. And those are some of the things we often forget about that are as important as taking good care of the patient. I want to put in perspective what's going on right now and why I and a number of my colleagues believe that an Ebola pandemic in North America is unlikely. We should not be Chicken Little in this whole process and worry about the sky is falling. I mentioned that the animal reservoir for the virus is exclusively in Africa. The method to transmit the disease is contact with the reservoirs, and people in North America typically don't eat bushmeat or rubber wash dead bodies at funerals. To our best knowledge, Ebola and other viral hemorrhagic fevers are not airborne spread. The infection is lethal shortly after the patient becomes ill. And in the North American setting, our healthcare seeking behavior is such that when we're even a little bit ill, we seek medical attention, which is very different from practices in West Africa. We thankfully have an incredibly robust healthcare system, and that includes public health. So identifying the at-risk patient, testing them, isolating them, and dealing with all contacts is done a lot swifter and more efficiently here than it is in parts of West Africa. And think in the setting of viral hemorrhagic fevers and Ebola, there have been more than 40 Ebola outbreaks since the virus was first discovered in 1976, yet the historic death toll has been less than 8,000. If you think in the last 5 years, compare that to influenza, there have been significantly more deaths related to influenza in Canada in the last 5 years than there have been deaths from Ebola in the history of the virus. I'll put one quote up here, and I want to emphasize something. This is a quote from a professor of the London School of Health and Hygiene. Ebola is relatively easy to contain as long as you isolate any suspected cases and maintain good clinical practices to prevent transmission. The end part of that quote, practices, transmission. As one final thought as I conclude here, Ebola does pose a risk, but it's very small. Public and provider fear is tangible. Some newspapers are referring to this as fearbola, not Ebola. There are greater risks that exist right now, and with regards to viral hemorrhagic fevers, mitigation and prevention are the keys. And if you think back to the 1990s when HIV and AIDS was prevalent, we're kind of experiencing the same kind of concern. And for those of you who've been through SARS 11 years ago, what we're seeing now is, albeit concerning, not necessarily as bad, and we managed to get through SARS. So in summary, I've talked about the current outbreak, I've talked a bit about what's going on within Ontario, the lessons learned from SARS, and put the whole thing in a bit of perspective with regards to a risk assessment. Just as I pass the baton on to my esteemed colleagues on this call, my email is, or my 2 emails are listed here. Feel free to contact me as you wish. I'd be happy to share any of the information I have with this presentation. If there are any specific questions now to what I've brought up, I'd be happy, I think, to take them now. Otherwise, there'll be some time at the end of this webinar to have an overall question and answer period. Thank you, Doug.
All right, thank you, Russell. That was an excellent presentation to sort of set the stage for us. Just a quick sort of technical issue. We had some issues with our colleagues in Alberta, Dr. de Caen and Dr. McKenzie. It looks like, okay, Allan, I guess, is re-disconnected. So we just had some feedback there because you had your phone and your microphones going, but I think we're good now. And before we move on to further east, out to Nova Scotia with Dr. Travers, we will take just a couple of quick questions. You mentioned about not recommending eyewear, like safety glasses. Michael's asked, are you doing anything specific with staff that wear prescription lenses?
For staff that wear prescription lenses, they obviously need those prescription lenses to have good visual acuity. So they're able to keep them and continue to wear them. That's not a major issue as long as they're cognizant of the fact that they've got to be exceptionally careful not to fiddle or adjust them while they're providing patient care or while they're wearing their PPE.
Okay. And Corey asked a question, sort of when you were going through the special sort of precautions that we can take in modifying care and that sort of thing. He's asking, I think he's asking, and Corey, feel free to put a follow-up if I've misinterpreted this, but he's asking, how is Orange performing air transports? And he specifies, like, what are you doing anything specific for the equipment of the aircraft itself as far as precautions or preparations? I think he's referring specifically to the vehicle.
The aircraft that we're using is a Pilatus PC-12, and it allows us to isolate our flight deck crew from the patient care compartment. And the patient care compartment is large enough that we can put the patient at the back of the aircraft and have it 2 to 3 meters from the flight crew. Our aircraft also has a very large rear loading cargo door that allows us getting into and out of the aircraft. I mentioned the issue with regards to the patient transport unit, Transport Canada. That's an issue we're dealing with. And then the materials and items within the aircraft itself are either covered or otherwise removed from direct access so that we minimize the possible contamination of the aircraft. Once the aircraft is completed its use, they've got a pretty rigorous decontamination procedure with their aircraft maintenance engineers, and they themselves wear full PPE when carrying out that particular task.
All right. Well, thank you very much for that. We did have a few more questions come in, but I think we will hold these to the end as we do have a few more presenters to get through. So we do have Heather, Laura, and Michael a couple more questions, but we will save those for the end. And we will hand the virtual podium over to you, Dr. Travers.
And Doug, just confirm you can see my screen okay?
Yes, we can, and you sound great too. So.
Great, guys. Thank you very much. My name is Andrew Travers, an emerge physician and EMS physician hailing from Nova Scotia. I don't have any significant conflicts of interest relevant to this topic. I'm just giving me a chance to switch my slide here. I don't have any academic or financial conflicts of interest of anything to do with this presentation. And again, I'm happy to share the information with any of the stakeholders online and follow up to this meeting. I just want to show you, this is my home. I live in the small black square, which is Halifax. We've got a population of about 1 million people and an EMS system that is both ground and air that actually incorporates the entire province. So in many ways, very similar to what Russell had presented. With this population and the distribution, we have emergency departments which are in place. With those emergency departments, we have ambulance bases, about 150 ambulances out in dispatch. We have two air medical assets, so a fixed and rotor wing. We have medical first responders involved in our broader healthcare system, and we have primary healthcare teams and collaborative emergency centers, which are available to a Nova Scotian. And the question is the flow of patients within this province for suspected all the way through to confirmed Ebola cases. And I want to share with you some of the challenges that we've faced. Just to put things in context in terms of the potential flight times versus drive times from Halifax, which is our main Ebola receiving facility, to Sydney, it's about 5 hours drive, about a 50-minute flight. And from the other end of the province, it's about a 4-hour drive, approximately, to go from Yarmouth into Halifax. So certainly some protracted transport times for our population. One of the key things, though, is that our broad assumptions as a healthcare system is that there's no such thing as a 911 call for an suspected Ebola or a confirmed case. Everything is a controlled response and transfer. I won't go through the details, but from the 911 interface all the way through the patient's journey, we want to do some elements of control so that there is no such thing as an emergency type of phone call. We are, as Toronto is doing, minimizing the number of pre-hospital interventions that are done and recognizing for stakeholders that transport in itself is an intervention. How patients are moved by ground and air is like any other medical intervention. There's a dose, a route, and a frequency to moving patients. Whatever we want to do, we want to integrate patient flow within the province. And our healthcare system has certainly expanded the scope and role of our pre-hospital clinicians compared to normal operations. Just to put this into context, this slide illustrates that. We have the community, which may bring patients into our main hospital, or in Halifax, our provincial hospital. And that provincial hospital has, on the left-hand side of this diagram, a primary catchment area, those that live in Halifax. And the only true example of a type of patient that would come province-wide to our center is a trauma case. On the other side of this diagram is the regional role of the hospital, where they have their own primary catchment areas, and they would transport cardiac arrest, STEMI, stroke, or sepsis patients. And between hospitals, we have this science and type of practice, which is the interfacility transport of patients. What our healthcare system has put us into a challenge as a provincial system is this type of model. Essentially, any Ebola case within the province, suspected through to confirmed, to come to a provincial hospital. And other provinces have been faced with the same challenge about getting the right patient to the right center at the right time, but predicated on a transport of patients to a broader provincial Ebola receiving facility. And I want to share with you some of the challenges of looking at the different epidemiology that's a hospital compared to an ambulance unit or a transport unit. So I'm an epidemiologist, that's my subspecialty in, and so I had to break things down for the epidemiological triad of host, agent, and environment. And just when we compare the two, I know that healthcare facility has an ambulatory and an ambulance population, but for the most part, it's a voluntary group of patients that present to healthcare systems. An ambulance unit responds to 911 calls, a different cohort of hosts, which includes both voluntary and involuntary type of patients. In terms of the agent, we have for hospitals dealing with aerosol-generating medical procedures. Well, in the EMS system, we have to recognize we have both aerosol-generating medical procedures, but aerosol-generating transport procedures also. Patients will frequently cough as they're extricated from their home into the outside setting, into the back of an ambulance. Back to the healthcare facility side, you have episodic exposure to patients and controlled ways to decontaminate at that patient healthcare provider interface. For the ambulance unit, in terms of that agent stratum, is that there's a continuous exposure. The healthcare provider is next to the patient throughout the patient's journey, and it's very difficult to achieve concurrent decontamination. But perhaps the most important thing is that for the healthcare facility, it's a controlled and fixed environment, whereas for out-of-hospital teams, it's an uncontrolled and dynamic environment. Also, in healthcare facilities, our healthcare teams are working in a healthcare environment, whereas our out-of-hospital clinicians work both in the healthcare environment, the mobile healthcare environment, but also exposed to the patient's home environment. And lastly, where in the healthcare facility, guidelines recommend short and episodic exposure to patients. The exposure for our paramedic teams and nursing teams in the hospital setting is much more of a prolonged duration. So at the very end of the day, in the middle of this slide shows a standard ambulance unit. And to be frank, as an EMS stakeholder, we have more in common with a hospital elevator than we do with a hospital room. And the challenge for us is translating these guidelines. My role here also is to point out, trying to translate in-hospital guidelines to the back of the ambulance is difficult. The FACT guidelines, I support that they're written well and those things, but relatively speaking, there's still a paucity of information on EMS. And the key thing, in my interpretation of this, is that the guidelines are predicated on a direct-to-standard EMS ops model. In other words, a 911 call going to the closest emergency department that's appropriate for them. And the challenge for us is how do we have all these bypass types of protocols? And the interfacility recommendations are now coming in terms of moving forwards. The CDC guidelines do have an EMS bundle recommendations with the interfacility components. And again, it's predicated on a 911 direct to closest Ebola receiving facility model, not necessarily a bypass model, and recognizes some of the knowledge gaps and comments on the heterogeneity of the EMS environment. But there's something else too, as EMS stakeholders, we have to pay attention to. You probably cannot read this, but within Nova Scotia, we have occupational health and safety legislation, where not only do we have to provide safe environments for our patients, but also for our healthcare providers, and balancing the OHS legislations against published guidelines, against patient care standards, is an increasingly complex thing that we're facing. And the last slide here that I want to show you is the way things work within our province here. We have, at the very first point of contact, the 911 call, we have the patient online, we have the paramedics on scene, and we're quite fortunate to have a medical officer of health an infectious disease specialist, and a transport physician also on the telephone line. And where the medical officer of health and the paramedics and the patients and the infectious disease specialists help determine patient risk on the left-hand side of this table to determine high or low patient risk, the role of the EMS operations and of the EMS physician is to determine the transport risk. And are they high or low categories of transport risk? And this is a decision tool that then helps us define what are the basic and enhanced levels of PPE and the types of precautions they would use moving patients from one hospital to another. At present, we are still working on an optimal way of moving pediatric cases within the province and hopefully going towards the strategy that Russell had shown, where critical care teams will have some smaller cohorts of people specialized in the complexities of infection prevention control in a critical care patient with the appropriate PPE. But we are still working on that type of model moving forwards. And again, I'm open to answer any questions moving forwards, but at this point, perhaps I'll hand it over to Mark if there's no questions at this point.
All right. Thank you, Dr. Travers. Once again, an excellent presentation giving us another perspective from a different part of the country and how things are working out there. So let's move on to the eastern part of the country, out to Edmonton with Dr. Mark McKenzie with Alberta Health Services and STARS. Over to you, Dr. McKenzie.
Great, thanks. With me, I have the real brains behind the operation, which is our operations folks. So I'd like to also introduce Kevin Welk and Brad Witcher, who are part of emergency management and planning. Great. So what we'd like to just touch on over the next 10 minutes or so is how our current emergency management structure in AHS EMS has contributed to the planning and also for the retention of lessons learned. Talk a little bit about planning and response, some of our challenges, and some of what we look forward to in the future and what we've learned from Ebola planning. We are still early enough in our transition in AHS EMS, which occurred in 2009-2010. Before 2009, we had about 70 different municipalities and agencies which were responsible for EMS operations. And that transitioned to one central oversight in 2009. In 2010, the same thing happened for air ambulance. And I think it's worth mentioning, as both Russell and Andy spoke, you could tell that there was a centralization of services and oversight of dispatch and such. And the people who are in EMS planning right now can still remember the way that it was before, when we had so many different EMS operations, municipally run system. As Russell was talking about the lessons learned from SARS, we went back to look for legacy documentation and really didn't find any. And so just a comment as how important it was to have central oversight, central direction. We went from 37, I think, dispatch centers down to sort of 5 right now. And it's been incredibly important for both planning and, I'm sure, retention of lessons learned. Emergency management planning and pandemic planning now have single oversight provincial. Who's speaking next?
Myself, Brad Witcher. What I'd like to touch on here on these slides, some of this has been touched on by Dr. Travers and Dr. McDonald already, but I'd like to speak to the foundations from which we built our current existing EMS interim Ebola guidance. More specifically around the challenges and how they contrasted versus our routine, what would be our routine planning process. So generally, when we have surveillance or hazard monitoring indicates this potential hazard or threat, our first course of action would be to consult with our pre-existing plans and any of those plans that would address that specific threat. So in the case of Ebola, our first go-to was the EMS pandemic plan, the current existing document. When we first started doing the planning back in August and referenced the EMS pandemic plan in Alberta, what we were confronted with was a plan that was very much influenza-based or influenza-like based and lacked some of the specific content that was required to in a lot of ways manage effectively and safely for our paramedic healthcare workers the consequences of the Ebola virus disease. I think some of that can be accounted for the fact that influenza, we encounter it annually, and the other side of that was that it has a low impact on our paramedic health and the staff's health in general. So we were looking at a plan that did have some of the framework that we could use, but really lacked in providing us the essential information to protect our staff. So our next move was to consult with our overarching EMS emergency management plan and to try to bridge some of the gaps that we encountered in referencing our pandemic plan. And as we went through our overarching emergency management plan, what we began to notice is that this plan, although again we did have a lot of good information and specifically towards the command and control structure that was previously mentioned, what it sort of reflected for us was more of an MCI type of framework, the traditional, I guess, emergency management plan as most people would associate with the pre-hospital environment. And really what it focuses on is the reservation of capacity to both the healthcare system and as well as our EMS system. So with still not having the fundamental essentials in front of us to manage and safely respond to the Ebola virus disease, we began a process of consulting with national jurisdiction EMS. We consulted with our colleagues in other areas of healthcare and really started from the ground up and started redeveloping some of the pandemic plan that was very much influenza-based, more towards an all-hazards approach, and then really getting down to the specifics as more information became available to us in how to manage and safely protect our staff from the consequences of Ebola. So some of the specifics have already been mentioned, so I won't bother going back over them. But many of the same I guess hurdles that Dr. Travers talked about in how we were going to manage the pre-hospital content of Ebola versus what was readily available as being mostly in-facility-based planning. Once we did have some of that information, we began developing our plan, and we worked with, again, our jurisdictional partners across the country, and as well as our colleagues in other areas of healthcare, and adopted and adapted their planning elements towards the pre-hospital environment. And we then authored our interim guidance on Ebola virus disease, and we maintain the interim guidance title because more information is bound to evolve. This plan is bound to develop and adapt as we receive more information and better practice around managing the consequences of Ebola specifically.
So, Andrew, as Brad mentioned, Andrew did a great job talking about some of the challenges that we faced in planning for EMS transports. Russell did a great job talking about some of the strategies that need to be implemented to mitigate that. I'm not going to go over those, but briefly, the interim guidance that Brad's talking about initially came out in early September. At that time, we had all EMS crews designated as responding to potential Ebola cases. They were using what Russell referred to as standard PPE that included impermeable gowns, face shields, and N95 masks, because those were standard practice on EMS units. All the EMS crews were doing point-of-care risk assessments for every patient encounter. We were looking for fever and exposure history primarily. Now, exposure history could be through travel history or through occupational exposure. If the patient, if that screening was positive, then similar to what Andrew was talking about, our EMS crews would initiate a conference call with the medical officer of health and any other specialists that needed to be consulted with. That would determine, amongst other things, the transport destination, and in Alberta we have 4 designated receiving sites, 1 each in Edmonton and Calgary for pediatric and adult patients. September 12th, we had a person under investigation present to, or what became a person under investigation present to a rural hospital site in Alberta. The patient was febrile, they had other signs and symptoms associated, and they did have a positive travel history to one of the outbreak countries. The patient was stable, there was no need for critical care transport. They subsequently went on to test negative for Ebola, but this case, along with another person under investigation that came out later, brought out some important learnings for us, and that was that while the basic PPE that we had in place and the procedures that we had in place were adequate to deal with the threat from Ebola, they were not adequate to deal with the perceptions of our staff, the fears of our staff. We got credit to our leadership. We got direction from them that it wasn't enough simply to prepare for the threat. We also had to plan to meet those perceptions and fears. Next slide, please, Mark. So that started our process of rolling out enhanced PPE and enhanced a cohort, if you will, of EMS strike teams. They initially started in Edmonton and Calgary. They were equipped with enhanced PPE, one-piece suits, very similar to what previous presenters have described. We're now expanding that to, as you can see on the slide here, to at least 1 team in each of the 5 zones, and in some cases there may be additional teams, just because of the large and diverse geography that we face. Next slide, please, Mark. The picture that you see, the map on the top left, that was actually the person under investigation that I just described. And very similar to what Andrew was describing, the one on the top right is an over 5-hour ground transport. That's probably under ideal conditions. And that's something that it would not be atypical for our providers. So we face the same sort of challenges of practitioner fatigue, dehydration, heat-related illness, fogging, just because of the PPE that they're wearing. The AHS studies are quoting approximately 11 degrees Celsius heat load added to whatever the ambient temperature is once the practitioners are in PPE. This is putting them at risk not only of heat-related illness, but there's also a secondary risk of EVD exposure. Anytime you're fatigued, dehydrated, it can impair your critical thinking, your judgment, your fine motor skills, and put you at greater risk of contracting or having a breach in infection prevention and control. Some of the things we're looking at to mitigate that are frequent rotation of personnel. For many of these ground transports, that's going to require at least 2 ambulances, probably not less than 4 responders. And then where along the way do you stop? It's not ideal to be donning and doffing on the side of a highway, especially with the weather we have in Alberta. Some of the other mitigation components that we're examining are things like cooling vests. They might be a good option for helping prevent against heat, but they're not necessarily going to address some of the fogging issues. PAPRs have been mentioned. Positive air pressure, PAPRs may help prevent the fogging, may help provide some cooling. The air ambulance might be our ideal solution, but we're still facing gaps in Alberta for provision of air ambulance to potential Ebola cases. And on that note, I'm going to turn it over to Mark.
Well, some of our challenges are, in fact, aircraft. We have a fleet of 11 King Air 200s, and there's no way right now to meet any of the requirements that are put out by any of the guideline organizations. So, for example, unable to regulate the airflow separately between cockpit and cabin, seats are clothed. If without an isolation bag for the patients, the pilots are actually sitting in the hot zone within 2 meters from patient, the way that our aircraft are configured. This, for example, is from Fort McMurray to the University of Alberta Hospital in Edmonton. This is a screenshot from our chart of call, and you can see at very best with fixed wing out of Fort McMurray, that's a 179 3-hour transfer from door to door. So long distances, current gap still exists within air fleet to do these trips safely. We do not have specific critical care expertise options currently available within the strike teams. So the strike teams are medic with expertise in PPE and advanced PPE at that level of care. As far as adult critical care requirements or pediatric critical care transport expertise, that's still something that we look forward to building into our infectious disease response. Some of the solutions that we've looked at for air are kind of interesting. The Canadian Air Force was contacted and have been pretty unresponsive, I'd say, so far to helping with solutions. Our operations folks contacted, you can see in the top right slide, that's Phoenix Air that has a couple of these types of aircraft in the U.S. These are the guys that did the transports from West Africa to the U.S. and they've said that they are essentially sole contracted to the U.S. government. So any movement there is going to have to come from federal level. The 3 slides more at the bottom are more likely to help mitigate some of our gaps. That's a Caravan in the lower right. We actually have a couple of those in Alberta, including one of the aviation providers that currently operates one of our King Air 200s, and they have shown some interest and willingness, obviously at cost, to make a Caravan available. 4 of those bio bags at the bottom have been ordered, 2 pediatric, 2 adult. We don't have our hands on those yet, but a simulation is planned in the next month or 2 together with the bio bags and staff and the Caravans to see if that would provide a solution for us. Go ahead, Brad.
Thanks, Mark. So we started off with an expectation that simply our EMS, our existing EMS pandemic plan would be sufficient enough to manage Ebola. We've gone through a lot of work, not unlike the rest of the country in both EMS as well as in facility. And what we've come up with at this point is a significant increase in knowledge and awareness around the different types of hemorrhagic fevers and the, I won't say lacking of our pandemic plan, but certainly our focus on influenza with our existing pandemic plan. And we've addressed a lot of these issues. As Mark just went through, we still have a lot of pieces still left to be determined and put together to provide a truly comprehensive manner in which we'll be able to transport suspect and confirmed Ebola patients into the future. Not only Ebola, but what we perceive this to look like in the future is management of all infectious disease. And there's a couple slides on the right-hand side that show some of the different situations going on as far as emerging infectious disease internationally right now. And our hope is that the work that's been accomplished to date and the collaboration that we've had, the opportunity that we've had to really make this stride forward in transporting infectious disease doesn't stop halfway done. Mark had previously mentioned we've just come out of a transition phase in Alberta, and back when the SARS event occurred, we were very much siloed into many different smaller jurisdictions, and now we're at a provincial oversight, and this is really our opportunity to take the lessons learned and apply them to our provincial system. We plan on doing that. We plan on moving forward, regardless of the impetus of Ebola. There are many things that we've begun that we will continue to work at and put together for the future. So the way that we plan to do this is to have an overarching document, again, that will be termed our Emerging Infectious Disease Management Plan. What we find is that there is certainly, through our planning process, there was certainly a framework that was available to us through our pandemic plan, and we utilize that right off the hop, and we plan on doing that same process, but having it documented for the future. Then we can apply specific treatment modalities, PPE, safety, towards the threat that emerges, the specific viruses and infections, based off the generic plan that we build. So what we look to do is to consolidate lessons learned into an overarching plan that will be able to then divide up into the specific content required to manage future emerging infectious disease.
Awesome. Thanks, guys. Thanks, everyone. Over to Dr. de Caen.
Doug, do you want to pause there for 2 seconds?
No, your slides are up. If you want to just sort of wrap this up for us, we'll just finish up the presentation and get to some of the questions.
That's great. Thanks, everyone. What I'm going to do is I'm just going to take a few minutes just to kind of pull together, I think, a lot of information that gives you a sense as to what's happened in the pre-hospital environment and the interfacility environment in general, and tell you what we know and, unfortunately, maybe more of what we don't know when it comes to how we're supposed to be transporting infants and children with Ebola, or I think the bigger issue ends up being with children that we think are at risk for Ebola, and we'll talk a little bit about that. The statistics, I think it was Mark, or maybe Russell was actually speaking to the whole concept of fear Ebola, and I think what's happened is that there has been so much hysteria that's being created coming out of some, yes, awful statistics that come out of the West African experience that I think we need to put in context of what this actually means if we face a disease like this in North America. You're talking about pediatrics, children that are actually affected by this illness not doing well at all, but this is also in the setting of very late presentations to resource-poor healthcare facilities. And I think, speaking with colleagues, pediatric critical care and pediatric infectious diseases colleagues that have been overseas over the last couple of months in West Africa, clearly early presentation the management of these kids is really not that different than what you'd end up seeing with, in terms of the management of the patient himself or herself, how you'd end up managing a patient with severe cholera. And the 70% or 80% mortality rates are definitely not what's reflected if you're dealing with children with early presentation. I think the bigger risk to infants and children in Canada in the setting of this Ebola crisis, shall we say, is that the screening tools that we end up having to identify high-risk patients, which ends up being fever as well as travel contact or contact with someone or occupational contact with patients with Ebola, is that the false positive rate is huge, and the risk when it comes to infants and children being identified as being potentially Ebola positive, but not having Ebola and effectively suffering the consequences or them being the collateral damage of a healthcare system that is struggling to deal with, and you've heard about this over the last hour, struggling to deal with how best to move these patients. That's something that I think we need to be very cognizant of. You know, the children that end up coming back from West Africa, that come back as families, and that's what we're going to be seeing. These are kids that are much more likely to have other causes of fever. It's going to be malaria. It's going to be dengue. It's going to be meningococcemia. And I think one of the things that really hasn't been spoken about that I think is going to have to be looked at when it comes to lessons learned out of this whole global experience is going to be at the same time that what's been happening in West Africa with Ebola and outcomes, what's actually been happening when it comes to morbidity and mortality in West Africa when it comes to dengue patients and malaria patients. You know, what's happening right now is these adults and children that are presenting into those centers, the great fear is Ebola, and the concern ends up being is that the care that they would have received before for more specifically for other diseases which have very different treatment algorithms, including, you know, those infectious diseases I just referred to. I think there is collateral damage, and I think we're going to see that here potentially in Canada and in the U.S. when we're dealing with screening tools that have such a high false positive rate that they basically, the worst case scenario is we end up leaving a child untreated or poorly managed in an emergency department, or we just throw them into the back of an ambulance and are afraid for our own lives as healthcare professionals and don't provide the excellent care that we otherwise could provide. So I think that's just a cautionary note. So what I've said to our transport team are you know, one of the big concerns that came out initially was what happens if the screen is positive. I'm dealing with a child that is febrile and the parents have been in West Africa, and this kind of addresses that whole Ebola issue. You know, most children, if they're going to be infected, they will have had primary contact with someone that by the time of the pediatric presentation, it's very clear that the adult ends up having Ebola or an Ebola-like illness. So this whole issue of, oh my gosh, is this febrile child actually going to be an Ebola-positive case? I think there's been a lot of hysteria built into that, and I think we've tried to diffuse that in many of our transport teams. So the unknown is much more likely going to be a known. And I think for critical care teams, the sad reality is, well, not sad reality for the critical care teams, but the sad reality for our EMS colleagues is most of these kids, when it comes to moving these patients into the Ebola centers, they're going to be moved early. So as I said right at the beginning, these are patients, they're not presenting into Canadian hospitals 20% dehydrated. These are usually, patients will have been symptomatic for between 3 and 5 days before they meet that threshold where, you know, they're going to be spewing fluid from all of their orifices and at high risk of dying in transport. These are not critical care transport patients. These are actually going to be febrile children that are relatively asymptomatic, that are early in the disease state. They are going to be moved by our EMS colleagues. They're much less likely to be moved by pediatric critical care and neonatal critical care transport teams. So I think, once again, just diffusing that whole hype about what this risk is to critical care transport, I think it's much less and it's much greater for our EMS colleagues. I'll just tell you very briefly about, in discussions with colleagues internationally about what they've been doing, and I think this, once again, comes back to how we end up balancing cautious care with responsible care, recognizing that Ebola is going to be very, very unlikely to be confronted by us in North America. Boston Children's has effectively shut down all air transport out of Massachusetts. They end up going, they did end up having a reasonably robust air transport system, which included rotary resources. They're no longer doing it. Everything is by ground. Their pediatric team will go out, basically goes in the back of the ambulance. When they return to Boston Children's, everything that is on the inside of that ambulance is disposed of. So there's a resource issue there, and also what that actually means when it comes to the ability of their team to respond to multiple cases that don't even include Ebola is clearly a concern. So I think one of the concerns out of that is Boston is one of the international leaders. Is that an isolated response? No. In Little Rock, Arkansas, probably the second largest pediatric transport team in North America, thousands of patients being moved annually. All air transport has been shut down because of those concerns that you heard Russell and Andrew and Mark speak to, the inability to safely transport not only the patients but protect the healthcare professionals. So basically they are now dealing with long ground transport times being done by EMS and by potentially by pediatric critical care practitioners, but their long ground transport times are a fraction of what we're facing here in Alberta, and I'm sure in Ontario as well. And then finally, the CAPHC transport team, which is one of the golden standards internationally. This is based in southern London. Basically, what's happened is once again, all air transport has been shut down for infants and children with potentially with Ebola. Ground transport is right now, yes, being provided by EMS, or that's what the model is, and they're still working out a model as to what would happen in terms of involvement of the pediatric critical care transport teams. The other reality is because of I think this is the hype, because of the hype that exists around how awful the outcomes are with delayed presentations, there's also a concern that actually there is no plan as to how or whether infants and children with Ebola would be cared for in a critical care environment in the United Kingdom. So you want to talk about significant implications when it comes to care for children not only with Ebola but with Ebola-like illnesses. That's a draconian extreme that's being spoken about in the United Kingdom right now. I won't. This has been spoken to already as to how this is going to work in Alberta. I think we've all bought into the model that if whoever is going to be involved in transporting patients with Ebola-like disease, we better make sure that these are people that are not only well-trained, but they're experienced, they're practiced, they do this as much as possible. Being a pediatric transport team that potentially moves one of these patients every year or every 2 years, I think ends up being fraught with problems when it comes to the risk to healthcare professionals, mistakes being made, and when it comes to the use of PPE equipment and PAPRs. So we have bought into the fact that these paramedic strike teams are the way to go in our part of the country. Clearly, PICU is the medical group is willing to be part and assist with the medical control of these teams. I think I will leave with a final comment saying that I think it's wonderful. We're seeing numbers plateau right now in West Africa. It looks like they're plateauing. It's wonderful on one hand that we might not have to confront this as a problem in North America, but as I think you've heard multiple speakers say, the momentum should not be taken away from all of these initiatives that are being taken on to prepare for the next time, because there will be a next time. It may not be Ebola, but there will be something else, and I think it would be criminal for us to be sitting here in 5 years' time saying the same things that we're saying now, which is we really didn't learn our lessons well from SARS. We need to do things different next time. And with that, I'll leave it, Doug, for you to facilitate some questions and answers.
All right. Thank you, Allan, and to all of our presenters. As you can see in the audience, that we've really covered a huge amount of information and not going very deep in a lot of areas, but really trying to cover as much ground as we can to leave it open to the audience for questions. So we do have a number of questions here. This question came in a couple of times, sort of asking specifically around in Ontario and in Nova Scotia, and the person asking the question commented that the folks in Alberta sort of answered this question already in their presentation. But in Ontario and in Nova Scotia, if you were asked to transport an Ebola patient today, and he's referring to what he's calling a wet Ebola patient, and perhaps we can get you to maybe clarify for the audience just for those who don't know, what a wet patient would be. But if you were asked to transport a wet Ebola patient today, is there a dedicated air EMS resource configured for this? So we'll start with Dr. McDonald in Ontario.
With regards to a quote-unquote wet Ebola patient, wet meaning they've got profuse watery diarrhea or large amount of vomit. So essentially it's wet. They're producing body fluids external to their body. Right now, because we don't have Transport Canada approval for the patient containment unit on board an aircraft, we technically cannot do it. And if it's a quote-unquote wet patient or a risk thereof, our plan is to use that device. So we are currently not set up to do it right now, nor is anybody else that I know of across the country. Right now, that's our only stumbling block.
Okay. And Dr. Travers, I can see your microphone is muted, so hopefully you're going to unmute your microphone before you answer. But in Nova Scotia, do you have an air resource available for this?
So at present, we do not. I think one of the important things to understand is that our models have all been predicated on bringing patients safely to a provincial Ebola receiving facility for all the complexities of their care. But that doesn't discount the importance of that local hospital providing optimal medical management. So we would not subject a patient to hazards of transport if adequate care could be provided on site. Plus, there are discussions of moving some of the lab testing to a mobile platform. So the patient would remain at their local institution, but the ancillary testing on Ebola would be brought to them for guidance. Plus, with the telehealth communications, any patient within our province would have access to the specialists by phone and those types of things. But we're in the same circumstance as the rest of the country. We don't have that capability of a wet, unstable, critically unwell patient to be flown from one hospital to another.
This next question came in sort of along the same vein. Came in from Heather, and she's asking, are any of the jurisdictions recommending any draping procedures for the inside of a land or air ambulance to contain bodily fluids?
From the land perspective in Toronto, there is a draping procedure that they've got that we've put into place to essentially cocoon the back of the land ambulance and remove any potential risk of exposure to whomever's on the stretcher to the rest of the vehicle. And then that's disposed of after the patient's been transported as part of the decontamination and cleaning procedures.
All right. Thank you, Dr. McDonald. And if anyone else wants to jump in with any, if you're doing anything differently in your jurisdictions, feel free to jump in. Going back to, maybe we'll stick with you, Dr. McDonald. We had the question about the glasses. We had a follow-up question about managing the use of reading glasses, so prescription reading glasses that are necessary for the healthcare provider to perform close work, but not necessary for them to be wearing all the time.
It's required for them to do work that they would expect to be needed done. My English isn't very good right now. If they needed to do something that's required as part of patient care, they should be using them. And they'll need to be protected behind something because the prescription glasses were probably not going to provide proper eye protection, so a face shield or some other barrier method. But the user's got to be cognizant of the fact that they've got to be careful in not manipulating the glasses while they're providing care, and then as part of the PPE doffing or removal procedure, those eyeglasses have to come off and be decontaminated.
Okay. The next question came in from Colin, and maybe we'll send this one out west to our folks in Alberta. He's asking, will your pilots have to don PPE to exit the aircraft?
What's that? Basic PPE. So it's Mark McKenzie here. It would be basic PPE. They're not going to be required to wear personal protective equipment, certainly while flying. That was looked at and thought that they would be unable to do their function safely while in full PPE. So without actually, don't have a specific answer as to what that would look like, but probably just basic PPE, gloves, gown before they exit, but nothing specifically over their eyes or on their head, anything like that.
Okay. Dr. Travers or McDonald, anything different happening in Nova Scotia or Ontario regarding the pilots exiting the vehicles?
Routine PPE for us.
And routine PPE, Travers.
All right. Next question we'll send out to Dr. Travers. Catherine's, being the epidemiologist, maybe you're the closest one to being able to answer this one. Catherine's just simply asking, how long does the virus live on fomite surfaces?
Guys, that's a great question. I'd be honest, I would be in air to provide an answer on that. I think there's, unfortunately, I don't have that kind of information available to me. I can, again, take that question offline to answer it.
Sure.
Anyone else?
Anyone else know the answer to that one? How long does the virus live on surfaces?
I've asked the question to my colleagues at the CDC, and I get conflicting answers, so I don't think there is a definitive answer.
Yeah. All right. All right. Darlene is asking, what would be the anticipated fetal or neonatal mortality rate in the North American healthcare environment versus West Africa? I think, Dr. de Caen, you mentioned what the mortality rate is in West Africa, but what's the expected mortality rate in North America?
Well, that's a difficult question to answer. I can say that the cases that have been reported from West Africa of maternal infection, in advanced pregnancy have been they're limited reports, but honestly, it's very poor outcome. But once again, I just want to stress this is poor outcome in the setting of delayed access to delayed presentation, limited resources. So I think this is the problem. We need to put all of these statistics in context. So and once again, as part of that, those when it comes to what the experience has been with those. With the neonates that have been born out of those cases, we're talking very small numbers that have been reported, their case reports. And my understanding is that those cases that have been reported have been very poor outcomes.
All right. We did have a question that sort of is looking for sort of clarification. She says clarification/curiosity, and I think this came in while you were presenting, Dr. de Caen. She says, re Ebola transmission or / risk in the pediatric population. You mention of a history of exposure to adults with Ebola as part of the risk assessment. She says, globally, are there any known confirmed cases of child-to-adult transmission, child-to-child transmission, and what about maternal-to-child transmission?
So once again, all the experiences coming out of West Africa. The interesting thing is that what's been reported in West Africa is that although when children come down with Ebola, outcomes are poor. Once again, that's you need to put that in the context of the resources, how kids present, and the resources available to treat them. But in general, when it comes to the risk of them actually contracting the disease in West Africa, it's actually been less than what's seen with adults. And the reason behind that is that, at least in the cultures involved in West Africa, children do tend to be somewhat distanced from from being present, preparation of the bodies, the kind of the end of life care that and afterlife care that actually happens for in the homes where people have died from Ebola. So risk of contracting it less than seen with adult to adult or adult to so the risk is less. I think when it comes to child to child, there are reports out of West Africa, but honestly, when it comes to extrapolating so many of these statistics, I'm not sure whether or not we should be trying to extrapolate these, to be honest.
Right. Thank you. Michael sent us a link to the CDC's website regarding how long Ebola survives, and their website gives us a nice definitive answer of several days. So they're not very specific about it either, sort of highlighting the lack of clarity around some of these issues. The next question that came in is for you, Dr. de Caen. It says the last presenter stated that their PICU would not transport patients. She's asking what is meant by that statement. Transport where? I think I'm assuming we're only referring to interfacility transport. But she goes on to ask, is there a plan for a newborn, like i.e. keeping mother and child together?
That's a really good question. As things stand right now, our approach here in Alberta is if that screen ends up being positive, the screening questions end up being positive that identify a child at being high risk of having Ebola, PICU would currently not be undertaking the transport of those patients, whether it's by ground or by air, the pediatric intensivist would be helping as medical control or one of the medical control officers to be involved supporting the paramedic strike teams. That's an Alberta model. I'm not saying that's a model that is going to exist in 12 months' time. I think what you've ended up hearing is that this is very much a dynamic, a dynamic process. But I think it comes back to the numbers game, right? The people that you want to be looking after these patients ideally would be a balance of individuals with lots of experience caring for critically ill patients, as well as lots of experience with caring for patients with Ebola or at risk of Ebola. And unfortunately, in Canada, not just Western Canada, but throughout Canada and throughout North America, that perfect union of experienced people that also have critical care skills doesn't exist. So, short answer, yes, in the short term, pediatric ICU transport teams in Alberta will not be looking after these patients in the interfacility transport environment.
All right. And anyone else on the panel have anything to add? I want to make sure that we include if you have any differences from your perspectives that you'd like to contribute to this.
Can I just I'll throw this back to Russell, because I think this is a number that had actually come out of a conference or a webinar that was based out of Toronto, and just to give the context of what the anticipated Ebola load or number of cases in Canada would be over the next 3 to 5 years. Russell, do you want to comment on what that number was that was quoted?
The number was actually very small. It's barely into the double digits, and that's spread out over quite a long period of time, and that's predicated on the outbreak in West Africa proceeding at a rate consistent with what it's been over the last 2 months. And we've already seen that not to be the case in the last 2 weeks. It's kind of leveling out or peaking out. The facilities that have been set up in the province of Ontario, and there are 11 designated facilities, just geographically we're so darn big, have set up to manage individual cases or very, very, very small numbers within each facility. So they're not anticipating massive outbreaks like we had during SARS, where at one point we had wards of hundreds of people with the particular virus. That's not the case for Ebola.
Thanks for that clarification. I think that's a really important sort of theme that's come from this, is we're trying to extrapolate from West Africa, we're trying to extrapolate from our experience with SARS, but it's really very different, the situation. Next question has come in. Maybe we'll start with you, Dr. McDonald, to see if you can. I'm not sure who might be able to answer this, but the question is asking, does Canada have Transport Canada approval to repatriate any Ebola persons working in affected countries?
Right now, any repatriation of Canadians abroad is going to be a federal government jurisdiction and issue, and they're actually working with the Canadian military to pull that off. Part of our working group within Orange have military affiliations, and they're part of the team working on that. Right now, there's no definitive plan, although apparently there is a federal government plan to repatriate federal government employees, particularly with the National Public Health Lab group, who are currently in West Africa, should they become affected with the virus. And the designated receiving facility for those few numbers of people would be one of our Toronto academic health sciences centers.
And a comment just came in, sort of using what resource to repatriate such a patient?
Because it's military, I'm not sure.
All right.
The military are an entity unto themselves with their own infrastructure, their own expertise, including their own healthcare system, so to speak, in terms of providers and experts. Some of them I have the privilege of working with, but they're developing a contingency plan strictly within military with military resources.
All right. This next question maybe we'll send out to Mark and the team out in Alberta. Sarah's asking, on a long ground transport, and I'll send it out to you guys since you guys do a lot of long ground transports, how do your teams plan on doffing contaminated PPE and donning clean PPE? And she's specifically interested in things like the N95 masks, considering they're only good for 2 hours, and we're talking about transports that are often longer than 2 hours. Do you have any thoughts on that?
Yeah, what we're looking at doing, like I said, we're going to have at least 2 vehicles with at least 4 practitioners, hoping to stop every 45 minutes to an hour, depending on practitioner comfort, etc. The ambulance that is following behind is going to be a rehab area or a prep area for the next crew to go in. It's going to contain biohazard containers for sealing all the waste. And in an ideal world, what we would like to do is arrange so that these stops to allow one practitioner to don and assume care, and the other practitioner to remove themselves from care and doff. In an ideal world, we want those to take place at healthcare facilities along the way, or barring that, at ambulance bases or other facilities like that along the way. That's the challenges that we're running into, is for some of these very long transports, those facilities are not located in convenient locations. So that's why we're looking at some of the technology to try and extend the working time that they can be in the PPE so that these stops can occur at appropriate locations.
All right. Well, thank you very much. Any of our colleagues in Nova Scotia or Ontario, anything different there with respect to changing of equipment, after the N95 masks and that sort of thing after a 2-hour period on a long transport?
Because I think it's Andrew here from the East Coast. I think this illustrates how we're trying to translate infection and prevention control guidelines to this very complex environment. And we're still working on it, to be frank. I think that's the illustration of, as a healthcare provider sitting next to a patient, even if whether wet or dry, if there's high-risk features in transport, i.e. transport times with a frequency of donning and doffing that exceeds an appropriate level, this idea of enhanced PPE may be required. In the form of PAPRs, as Russell illustrated, that's done for patient comfort, but also to reduce the frequency of donning and doffing. The challenge is, where's the published guidelines on that type of evidence? And I think that's collectively, everyone online here needs to help inform the complexities of out-of-hospital transport and how we can come up with more optimal guidelines for managing this. But as Nova Scotians, we're still trying to figure that out. How are we going to move patients from point A to point B safely for the patient and safely for the providers? And we, again, are still working on it.
Mm-hmm.
From the Ontario perspective, I echo what Andrew has to say with regards to the issues on the west and the east coast. We have the same problems. We went to the PAPRs to extend to about 2 hours to provide our frontline staff with some additional level of comfort and not having to change on a more frequent basis. But once you get beyond 2 hours, there is really no clear guidelines. It's uncharted territory, and we're trying to figure that out ourselves.
Right. Well, that's all we have for questions. So, Dr. de Caen, why don't I hand it over to you to make sort of any kind of closing comment that you'd like to make to sort of wrap this up?
Well, I think first of all, I'd like to thank all the presenters for taking the time to share their expertise and experience in what's led up to hopefully something which is going to be a building block for the future. I think when it comes to specifically the transport of infants, children, and high-risk maternal transport of patients like this, I think the takeaway message for me ends up being is that air ambulance transport and ambulance transport in general of these patients ended up being very much kind of it was the last thing on the list that healthcare authorities were going to address, and unfortunately, pediatrics is kind of the last thing on the last part of that list. So I think it is it's a valuable discussion for us to have. I'd like to think that this is hopefully an opportunity for ongoing dialogue. I know that the speakers that have been part of this discussion, this isn't the end of their Ebola experience. They're continuing to work collaboratively at a national level. And I think what I would hate for people to take away is that we have half-finished solutions to moving these patients. I think things have moved along dramatically in the last 2 months, and I think they're going to continue to improve when it comes to having a model which is going to be safe for movement of both patients and the involvement of healthcare practitioners. As I would encourage, if there are people that still do end up having burning questions or concerns, clearly the contact information for all the speakers are either available through their PowerPoint presentations, or I'm sure Doug will be able to make sure that those email addresses are accessible to people if they still have questions and concerns. So once again, a great big thank you to not only the speakers but also the CAPHC to being willing to host this session.
Oh, well, thank you, Allan, as the co-chair of this work and sort of leading this. It's really fantastic. You brought a great group of colleagues here to help us sort of walk through this, and I think it's great to see that we don't have all the answers. We're learning as we go. We're using what the experiences that we have had around SARS and what's happening in West Africa and extrapolating it as best we can. But as I think Dr. McDonald and Dr. Travers both said, we're learning as we go in some areas of this and doing a great job, I must say. So thank you to all of you for such a great presentation. And I think we'll wrap it up here. We do these webinars every Wednesday at 11 a.m. Eastern Time, and as I said, Dr. de Caen is one of the co-chairs of our Interfacility Transport Committee, and we do expect to have more content for our interfacility transport colleagues over the coming year, so keep an eye out for that. It's always great when we have a live audience, as your questions and comments really enrich the discussion, as we can see. But if you can't watch live, the recordings of these sessions are always made available after the fact on the Knowledge Exchange Network at www.ken.caphc.org. This is our last webinar of 2014, but we are back with a full slate of webinars in the new year. In the new year, we will be rejoined by the members of the former CIHR team in children's pain, who we did a whole series of webinars over a number of years. They're coming back to talk to us about whether or not we've actually moved the needle on children's pain over these past few years since we started our work with them. We'll have a session on service disparities for First Nations children and what that situation looks like across the country. We'll be covering mental health issues. We also have our monthly Friday webinars from our Patient Safety Collaborative and much, much more in the coming year. So thanks for joining us. Thanks again to our presenters, and we hope to see everyone in the new year. Thanks, everyone, and goodbye.